the artery is over it, okay, it will usually, the smaller, ha, you look at this, ba to? Nag-hump siya. Dito nag-hump, ha? Nag-hump. It is hump here. Oo. Mas ano ang hump kaysa sa neck niya dito. Ito, nag-hump siya dito. Okay. Can you still hear me? Ito, nagninik dito. Ito, nagninik. So, if this is hypertensive retinopathy, what grade is this? You have your papilledema.
4.
Oh, you have your hemorrhages. You have your cotton wool spots. That is your grade 4. But this is your classic central retinal vein occlusion. This is your pizza pie fundus. Look at this. You have your ketchup are your hemorrhages. Your cheese are your cotton wool spots, soft exudates, and you have your sausages. Yan. Oh, yan. Yan, oh, parang box cart. Okay. This one is your optic disc edema. Yeah? This is your central retinal vein occlusion. Ha? Yan. Yan ang hallmark niya. Parang pizza pie fundus. Ha? Okay? Okay na. Maalala na yan. Okay. Sige, next. Oh, nasa neuro-opta na tayo. Where is the lesion? Drawing sa papel. Sige. You draw, Uji. Oh, draw your your optic nerve pathway. Draw again. Paper, get paper. Oh, okay. Sige, draw. Kuha ka ng papel doon. Sige, you tell me, ha? I will wait for your answer, ha? Can you hear me? Okay, sige.
Yes,
You
ma'am.
draw. Ikaw, hindi mo na maalala, ha? Hello? Do you have an answer na? Wala pa? Sige. Are you drawing na on a piece of paper? Ha? Sige. Draw. So what is this generally? This is a right homonymous, a left homonymous hemianopsia. Left.
optic tract, Doc, right optic tract.
Right optic tract. No. 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 Optic tract won't give you discongruous lesion. Remember, this is you have your macular sparing. So where does macular sparing usually happens? The macula spared. So the vision here is still okay. It's still 20/30. Hmm? Oh, so the more posterior it is, the more congruous the lesion. Mm.
Occipital lobe, Doc.
Left homonymous hemanopsia, that is your
Occipital.
occipital lobe lesion. Yeah. Nagdo-drawing ba kayo? Ha?
Yes.
That's your occipital lobe lesion. Okay, sige. Read on it again, ha? That is your neuro-ophtha. Yan ang mga neuro-ophtha. Sino bang maging neuro sa inyo dito? Ha? Meron bang maging neuro sa inyo? Ha? Sino? Si Dr. Di Coco? Ha? Ha, Patrick? Okay, next. Mhm. This one, what is this? The left eye is normal, the right eye, the red ones are your scotoma, ha? Look at this one, ha? Yan ang scotoma. What's this one? The red one are absolute scotoma. Okay? What is the probable diagnosis for this? Any guess? Ikaw. May guess ba dyan? Ha? What? What? Ha? That is advanced glaucoma. Ha? One eye. Usually, cranial, pag mga lesions on the brain will usually give you bilateral visual field defects. Ha? Okay? Bilateral field defects. Okay? Dito na tayo. Wala na. Just naman tayo. Set A. Set B na. Mm-hmm. Okay. What do you think is this condition? Ay, ha? Okay. That one.
Annual spots, Doc.
The white ones are your exudates. Okay? They're exudates. You have your hemorrhages. So what do you think is this condition?
Hypertensive retinopathy.
This is your non-proliferative diabetic retinopathy with significant macular edema. Yan. Macular edema. Edema will usually appear as white spots. Caught your hard and soft exudates. This one is not yet on the, it's in the parafoveal area, but it will already Okay na? Okay na? Okay. So, your on the left eye, you have your soft and hard exudates, you have your hemorrhages. So, the left eye has a significant macular edema. The right eye is still on the parafoveal area. So, the vision here is still better than on the left. Okay? But this is diabetic retinopathy pa rin. Ha? Okay? Ibang stage lang. Okay? Okay. Pati na yun. Okay, this one. What is this? Bilateral. Wag na wag ninyo itong kakalimutan. Wag na wag. Wag na wag.
Oh,
Ha?
retinitis pigmentosa.
Correct. Correct.
Cotton wool spots na, Doc.
Hindi yan cotton wool spots.
Ay,
These
di ba?
are your bony spicules. Your
the
bony
ones-
spicules. Yan. Yan.
Okay. Ay,
Yan.
oh, yes, Doc.
So, what will you elicit from the history? The history of night blindness. Ha? Yan. Yan ang ano dun. History of night blindness from childhood. Since childhood. Ha? That's, hindi naman talaga yan bones, ha? Pero yan lang ang term. Bony spicules. Okay? So, this is your retinitis pigmentosa. Okay? So, huwag na ninyong kalimutan yan, ha? Okay na? Okay. We'll move on na. Okay na? Okay, next. This one, what is this? This is the right eye. This is the left eye. Okay, what is this? This is your branch vein occlusion. Branch retinal vein occlusion. This branch. Oh, the superior temporal branch. Okay, there is soft exudates, there are hemorrhages. Okay, that part only. Yun. Oh, yes, yes. Oh, the artery won't bleed. Diba? If there is occlusion of the artery, you will have your silver wiring. Silver wiring. It won't give you hemorrhage. Huh? So, if
Pallor of the
pallor of that part of the retina, it will be pale compared to the rest of the retina. Okay, so walang dugo. Okay? Yan. Okay. Oh, that one again. Where is the lesion? Doktora Kalipayan, where did you graduate?
Medal, Southwestern.
Ah, Southwestern? Ah, okay. Sige. Go back to your drawing.
Anong gagawin ko sa drawing ko daw?
Ang drawing mo.
right optic radiation.
Yeah, it's in the optic radiation already. But which part of the brain? Do you still remember the pie on the floor, pie on the sky? Huh? Pie on the sky is a lesion in your temporal lobe. This is a pie on the floor. This is
Temporal.
parietal. Opposite. Huh? Pie on the floor is parietal. Pie on the sky is temporal lobe. So this is temporal lobe opposite. So that will be, this is right. So it will be on the left. Temporal lobe. Okay? So, imagine your brain. Ano bang nasa taas? Parietal, temporal. Baliktarin ninyo, baliktarin. Ha? So, ang nasa taas, ang lesion niya nasa baba. Ang nasa baba, ang lesion niya nasa taas. But opposite. Okay? Yan. Sa anatomy, isipin niyo yung anong itsura ng brain. Ha? Okay? Okay. Isip mo na? Okay. Diba, yun ang utos, yun ang turo sa inyo ni Dr. Reyes. Parati dapat meron kayong ano sa memory nyo. Yung point of ano ba yun? Na you should always, dapat meron kayong association. Yan, association. Yan ang sabi niya parati. By association. Okay. Oh, this one, what is this? The periphery.
Dok, wala pong audio.
Okay? Okay. So, what is this again? This is bilateral tunnel vision. Where do you see tunnel vision? In what condition? Advanced glaucoma. So, this is a bilateral advanced glaucoma. Okay? Okay. So, we'll go now to our topic. The glaucomas. So, for you, what is the definition of glaucoma? How do you understand glaucoma?
There's an increased IOP, but
It is characterized by increased intraocular pressure with optic nerve degeneration. Something.
With optic nerve damage? Okay. 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 This is the definition of glaucoma. Huh? It refers not to a single disease entity, but rather to a group of diseases that have certain common features. Okay? Such as IOP, too high for the continued health of the eye. So, wala dyan sinasabi na definite na IOP. Ha? Walang ano na, what is high? What is high for the eye? Ha? Basta, in that particular eye, the IOP is high for the optic nerve. Ha? Then optic nerve head changes. You have your cupping or atrophy and visual field loss. Yung tatlo na yan. Ha? So yan ang parati dapat. The IOP, the optic nerve head changes, and the visual field loss. Yan ang ano sa glaucoma. Yung tatlong yan. Ha? Okay. This is your anterior chamber angle. Okay. Do you still remember the borders of your anterior chamber angle? Anteriorly, what is the anterior border of your anterior chamber angle?
Cornea, Doc.
The cornea. Which part of the cornea?
Posterior surface of the cornea.
Posterior.
Yeah, this is the posterior surface of the cornea. So what is the part of the cornea that is protruding, that abuts into your anterior chamber angle? Huh? It is like parang hump. Yan. What is that? Can you still remember that one? Okay, I'll give you a hint. It is the termination of your sesameous membrane. What is that? Schwalb's line. Schwalb's line. Yun. Okay. Mayroon na nga OSL. Schwalb's line. Okay. Then, the next, posteriorly, what is the border of your anterior chamber angle?
The anterior surface of the iris and the ciliary body, Doc.
Yes. Now, imagine always the iris like an accordion. Nakita ninyo yung accordion, para siyang may mga folds. Okay? Imagine that one. So when the accordion is folded, makikita mo ang kanyang mga humps. Ganon, pag ganon. But when it is open, when the accordion is opened, mag-flatten siya. Imagine your iris to be that way, ha? Kasi mamaya, when we go to your angle closure glaucoma, that is important, ha? Okay? So, from your Schwalb's line, the next is your anterior trabecular meshwork. Okay? The next will be your posterior trabecular meshwork. The anterior trabecular meshwork does not drain your aqueous humor. So, the posterior will drain your okay na? May audio na? Okay. So, your anterior trabecular meshwork does not drain your aqueous. It is only your posterior trabecular meshwork that will drain your aqueous. Then, the next to your trabecular meshwork is your scleral spur. Scleral spur. The next is your ciliary body band. So, the drainage of your aqueous will start from your posterior trabecular meshwork, until your ciliary body band. Your ciliary body band, that is where your aqueous is also absorbed through your uveous scleral outflow. Ha? Okay? Kasi dalawang ating outflow system. Later, we will, do you still remember this lecture? The outflow system of the anterior trabecular meshwork of the aqueous? Hindi na. Wala na? Foreign na to? Foreign na? Sige.
Foreign na, Doc.
Foreign na, foreign. Okay. Ayan, ito sinasabi ko sa inyo, ito yung mga, mga humps ng iris. Okay. So if you will imagine that later, babalik lang tayo dyan sa drawing na yan. Okay. Here's your ciliary body band na. Okay. So, the formation of the aqueous humor, okay, it is produced in your ciliary processes by combination of active transport, ultrafiltration, and diffusion. Okay? Now, this is the outflow system. Now, going back to the anatomy again. The ciliary processes. How many ciliary processes do you have on each eye? Hmm?
50 to 70.
Medyo tama na yun. Taasan mo pa. Higher bunker.
8 to 100.
That is 69 to 72 per eye. Okay? Yan. Okay?
No
Next.
specific na range, Doc? 69
Ha?
to 72?
69 to 72. Oo, yan ang range niya.
Specific
Ha?
siya na range?
Oo, basta hindi siya
Specific
bumababa
po
ng...
ba siya na range?
Sometimes it will go beyond 70, mga 72. Minsan 76. But at less than 65. Mm. Yan. So, the outflow system, this is the classical outflow. Okay. 80% of your aqueous drains through the classical outflow system. The outflow system, okay, will be like this. From the ciliary processes, your aqueous humor will be produced. Then from the posterior, from your ciliary processes, the aqueous will go to your posterior chamber. Then it will pass through the pupil. Then it will go to your anterior chamber. Then it will drain to your trabecular meshwork. Then from the trabecular meshwork, it will go to your Slem's canal. Then from the Slem's canal, it will go now to your collector channels. Then it will go now to your venous system. Okay? Yun ang parating alam ninyo. Diba? Yan ang parating alam ninyo. From your first year, alam na nyo to. Sa anatomy. Alam na ba? Huh? You still remember this? Okay. But mostly this is what your idea is, diba? Okay? So, let's go to the another drainage system. Okay. The 20% of your aqueous flows through your uveoscleral outflow. Okay? This one, it will go again to your posterior chamber, to your pupil, anterior chamber, but here, it will now be absorbed by your ciliary muscles. Then from your ciliary muscles, it will go to your supraciliary and suprachoroidal spaces, then to the venous system. Okay? Yan. Then it will mingle with your blood. Okay? Yan. Only 20%. Now, mostly of your anti-glaucoma drugs will affect the classic outflow system. It is only your prostaglandin F2A analogs that will act through your uveoscleral outflow. Okay? Okay? Baka wala na naalala sa pharmacology. I told you to read on it ba ya? Okay. Next. Okay, determinants of intraocular pressure. Okay? Now, the rate of aqueous humor formation, okay? The resistance to aqueous humor outflow, and the level of episcleral venous pressure. The normal episcleral venous pressure is 8 to 12. There's na? Okay na? Okay. Okay. So, your IOP, for example, if the rate of aqueous humor formation is higher and there is resistance to aqueous humor outflow, the IOP will increase. Okay? Now, if the aqueous humor formation is normal. The rate of aqueous humor formation is normal. But there is resistance to aqueous humor outflow. So, the IOP will increase. But even if these two factors are normal, if your episcleral venous pressure is high, is example, in your carotico-cavernous fistula, okay? Isipin ulit, carotico-cavernous fistula. Venous yan, ha? Okay. The episcleral venous pressure is high. So that the number 1 and number 2 are normal. But it cannot drain well because of the high episcleral venous pressure. Your IOP will still increase. Okay? So your drugs, to decrease the IOP, it will act either on the aqueous humor formation, it will decrease the aqueous humor formation, or it will increase the outflow system. The outflow capacity of your trabecular meshwork or your ciliary body. Itong episcleral venous pressure, medyo mahirap to. Wala itong gamot, iba na ito. Kasi nasa level na to ng venous system. Okay? So anything that will increase the venous pressure will also increase your IOP. Okay? Now, the clinical evaluation. The intraocular pressure. The normal range is 9 to 21 millimeters mercury with standard deviation plus of 16 plus or minus 2.5 millimeters mercury. Okay? Yan ang, kumbaga, most of the population has that pressure, has that normal range of IOP. But it doesn't mean that you cannot have glaucoma if your pressure is within that range. Okay? Because depending on the eye, we don't know what is normal for a certain eye. Iba-iba ang normal para sa mata. But mostly, most ng tao, yan ang normal IOP. Okay? Okay. Factors influencing IOP. The time of the day. Okay. During the 24-hour period, the IOP will change every hour. It is usually higher, sometimes in the morning and in the afternoon. So we usually, that is why sometimes we do your diurnal monitoring of your IOP. In order to know what time of the day the IOP will increase, para doon tayo magpapatak. Kaya lang, napaka-tedious naman yun. Every hour ka kukuha ng IOP. Ang pasyente mo, 12 hours na sa clinic mo. Parang, kung ngayon sa COVID, nahawa mo na ang pasyente, nagkawaan na kayong dalawa sa pagharap ninyo oras-oras. Parang, so, the season of the year, they said that during hot weather, tumataas ang IOP. Of course, ito, given to, pag mataas ang blood pressure, yan, the heartbeat, pag mataas ang ano mo, ang systole, oo. Tapos, in inspiration, your IOP will increase. During expiration, the IOP will decrease. Pero mga few millimeters lang yan. Few millimeters mercury. Mga 1 to 2. Then of course, genetic influences. May mga tao actually, na sa family nila, ang pressure nila is 25 millimeters mercury pero normal pa rin sila. Mga iba-iba kasi ang tao. But only certain people has that normal pressure, ganyang kataas, without damage to the optic nerve. Then of course, the age. Now, they said that as we grow older, our aqueous humor formation diminishes. So, dapat sa matatanda, mababa na ang pressure. Yan. So, pag tumaas ang pressure ng matanda, ibig sabihin may cause yan. May ibang factors kung bakit tumataas. Yan. Measuring devices, You have your indentation tonometer, your Schwartz tonometer. Have you seen a Schwartz tonometer? Yung pinapatong, nilalagyan ng weights? Ha?
Picture lang, Doc.
Picture lang. Okay, picture. Okay. This is just used for screening purposes. Ha? Hindi ka pwedeng mag-monitor ng ano dito. For screening purposes lang. Ang ano pa talaga, gold standard is your Goldman tonometer. Your applanation tonometers. Ha? Ah, okay na? Okay. The gold standard is your Goldman tonometer. However, because of AIDS and the COVID now, we do non-contact already. The non-contact tonometers, the pneumatic, the air puff tonometers na lang tayo ngayon. Huh? But still, but the ano talaga, the most reliable talaga is Goldman pa rin. Goldman pneumatic. Goldman tonometers. Oh, this is your Goldman applanation tonometer. Huh? Have you seen this one? Di ba pinapunta ko kayo sa clinic? Di ba? Oh, this one you should use this in a slit lamp. Ha? Hindi ito pwedeng hawakan mo lang. Ha? You will place fluorescent dye there. Then place anesthetic on the eye of the patient. Then this one will go in contact to your cornea. Okay? This is what you will see at the tip of the Goldman tonometer, because the tip is a glass. It is actually a biprism. Parang kinat siya, dalawang prism siya, kinat sa center. So, imove mo mayroong drum sa tabi until maglapat sila na ganyan. Ha? Yan, dapat up, or you'll start at 10 millimeters mercury, then you will have to rotate that until ano na silang ganyan. Yan. That's the end point. So then you will see at the drum, you will have pressure at the side. It is by 10. By 10. Tapos mayroong mga lines na you read that by 2. Huh? Okay, mahirap mag-explain sa ganito, no? Na walang clinics, ano? Okay. But you have rotated na at EVRMC, di ba? Yeah, you have done.
Not all, Doc.
Not all. Okay.
Naabutan kami ng COVID, Doc, na ano.
Really? Kawawa naman kayo. Oh, I hope COVID will be gone by January. I will let you go to my clinic next year. Diba? Is Dr. Di Coco there? Patrick, are you there? He was one of my favorite interns. Yeah, di ba Patrick? Wala, no sound? Ha? Wala na? Oh. Duty? Oo. So, this is your optic nerve, okay? Your optic nerve is composed of neural tissues, glial and collagenous supporting tissues, and blood vessels. It contains approximately 1.2 to 1.5 million axons. The cell bodies are located in the ganglion cell layer of the retina. Okay? Imagine that always. Your nerve fibers, your optic nerve, are actually axons of your ganglion cells from your retina. Okay? So, imagine, I always do this, explain this way to my patients. Imagine a broom. Broom, di ba? Yung broom, isang bundle ng ano ba yung tingting? Walis tingting. You put that in a bundle. Huh? At the center is a hole where your blood vessels will pass through. Okay? Will pass through that hole to drain the blood, the dirty blood, and supply the blood through that hole. Okay? The arteries and the veins, actually. The retinal arteries and veins. Okay? Can you imagine that? Oh, wala akong naririnig. Can you hear me?
Yes,
Okay, sige. So, the average diameter of your intraocular portion of your optic nerve is 1.5 millimeters. So, what is the size of your macula? The size of your macula.
5.5 millimeters.
It is the same as the size of your optic nerve. 1.5 millimeters pa rin. Horizontal diameter. Ha? Pareho sa macular area. Ha? Oh, isipin niyo pa place that in your mind. Okay? Yan. Then, the arcuate fibers entering the superior and inferior portion of the disc, the superior and inferior fibers are the more susceptible to glaucoma damage. That is why when we look at the optic nerve in a glaucoma patient, we usually evaluate the superior and inferior margin of the optic nerve. The neuroretinal rim. The neuroretinal rim is the Okay na? Okay. The neuroretinal rim is the border, the outer border of your optic nerve and the border of your optic nerve cup. Okay? So in between these two borders is your neuroretinal rim. In a glaucoma patient, you have to examine first the superior and inferior borders. Usually, the defect will start from that area, the nicking, the optic nerve nicking, the nicking of the border of your optic nerve cup. Okay? The blood supply of your optic nerve is your central retinal artery. This is the distribution of your optic nerve. Note that most of the axons that comprises your optic nerve mostly comes from your macular area. So, the difference now between your glaucoma, in glaucoma damage, the superior and inferior border ang unang tatamaan. But in papilledema, ang unang tatamaan, ito. Ito. The temporal border, yan ang unang mamamaga. Hindi ito. Ito parati. Because this is where most of the axons are, silang unang mamamaga. Okay? Next. This is your optic nerve, the optic nerve cup. Okay? Your nerve fibers. This is now your lamina cribrosa. Okay. Now, your lamina cribrosa is like a sieve. Parang saraan ba? Saraan. And they support your optic nerve. Now, when you lose glial tissues, yan, nagiging weak ito, so nothing will support now your optic nerve, kaya ang cup lumalaki. In glaucoma, you lose glial cells, the support here of your optic nerve becomes weaker, So, madali siyang, pag nag-increase ang pressure, madali siya ngayon magbaw. Madali siyang lumaki ang cup. Okay? Okay. Tell me if you don't understand, ha? You tell me. So, in glaucoma, you have loss of axons. So, yung 1.2 million and 1 to 1.5 million na nerve fibers mo, nababawasan na yan, ha? In glaucoma, because of damage. You have loss of blood vessels, small blood vessels, and glial cells. Okay. So, theories of glaucomatous damage. Now, before, ito ang yung mechanical history. They said, because of the increased IOP, the blood flow to the eye will decrease. The blood flow to the optic nerve will decrease. So, the damage now will ensue pag tumaas ang pressure. Kaya lang, paano ngayon ang normal tension glaucoma? Hindi naman mataas ang pressure. Why is there damage? So, as of now, the most accepted theory is your ischemic theory. The blood supply talaga, mainly the blood supply. Huh? So, anything that will decrease the blood supply to your optic nerve will cause damage. Okay? So these are the ophthalmoscopic findings in glaucoma. Okay? You have generalized enlargement of the cup. Okay? So, lumalaki yung butas sa optic nerve. Focal enlargement of the cup. Okay? Minsan, may cup, tas may nagninik sa taas, sa superior or inferior. Okay? Superficial splinter hemorrhages. Around the optic nerve, may makikita kang isang splinter na meron dugo na parang splinter lang. Isang dugo lang. That is sign of ischemia. Loss of nerve fiber layer. Okay. Now, loss of nerve fiber layer, you will appreciate that if you will use the green light in your ophthalmoscope. Kasi dapat normally, if you will look at a normal retina, especially in young, mga young mga less than 20 years old, you will see the striations of the nerve fibers if you will use the green light. But if you have loss of nerve fibers, mawawala yung striations na yan. Parang ano lang siya, parang uniform na lang na flat, na wala ng striations. Yan ang loss of nerve fiber. In green light, you will see the splinter hemorrhage as black. Black. In a green light, in your ophthalmoscopy, if you want to look for a splinter hemorrhage, you will see a black line running from the edge of your optic nerve, running along a blood vessel. Makikita mo yan, nakaganon. Black. Pag hemorrhage in a green light, black yan. Okay? Then, asymmetry of cupping between the two eyes. Asymmetry. Meaning, kung ang other eye, the cup is 0.2. The normal usually is 0.2 to 0.1 to 0.3 or 10 to 30% of the optic nerve, yung cupping mo. So, for example, the cup on the other eye is 0.3. The other eye is 0.5. So, magkaiba ang kanilang size ng cup. So, that could also be a sign for glaucoma. Kaya lang, this time, parang napaka-strict na ng diagnosis ng glaucoma. Marami nang ginagawa. Kahit cup asymmetry, kahit big cup, kahit ang cup niya is 0.8 na parang abnormal na, pwede pa rin yan hindi glaucoma. Hindi na ganun kasi marami nang ginagawa ngayon. Kasi if you will look through the the OCT, optic nerve OCT, the optical coherence tomography, the visual field exam. Pag normal lahat, that means normal yan, walang glaucoma. Kahit malaki na ang cup. Ha? Yan. So parang marami na ring changes. Parang ito lang, sa ophthalmoscopy lang ito. Parang if you want to do screening for glaucoma, dapat may makita ka dito. Ha? Before you can, even though if your pressure is normal, pag may makita ka na ganito, you are you are warranted to request for a glaucoma workup. Okay?
Okay, Doc.
Yan. This is your vertical elongation of the cup. Okay. If you will estimate now, what is the cupping? What is the cupping of this? The vertical elongation. Look, the superior neuroretinal rim is thin. This one okay pa. This one okay pa. Ito talaga ang thin out na. So the defect is here na. So what is the cupping here? If you will estimate the cupping through ophthalmoscopy, for example, nag-ophthalmoscopy ka, so sabihin mo ngayon, anong cupping? Tatanungin ka, what is the cupping of that one? Volunteer? That one is thin. Oh. If you want to see the edge of the cup, tingnan mo kung saan nag-iiba ang direction ng blood vessel. Tuman, dyan, yan ang kanyang border. That pale rim dito, yan, yan. That's the cup. Kasi tingnan mo dito ang kapal. Dulang. Yan, gumaganon siya, You can appreciate. May error of refraction yata itong aking pamangkin. Ano ba yan? Look at that. Para siyang nag-ano dyan, boom, ganun siya. Mataba dito, biglang lumiit, Layo-layo ka. See? Mas makikita mo ngayon ang white. Hindi pa rin. Ano ba yan? Baka may ano ka, color blindness ka. Sige, dapat ka na nga magpa-check ng ano mo. Okay, so what is the cupping now? Estimate of the cupping.
All the
Ha?
8.3.
Point what? Point.
0.5.
Tinuruan ko ba kayo before? Paano mag-ano? Sige. Mag-ano tayo, ha? Let us divide this into ganito. X. Ganyan. Okay. Nay. Okay. Divide natin to. Ayan. Sorry. Ano ba to? So, ano ba yan? Dito. Center. Undo. Ano ba ito? Okay, dito. Okay. So, sulat. Ito dito, siya, ang kanyang rim, from here to here, ang laki-laki. So, about 0.7. Sige daw, Koji. 0.7. Ito, dito, 0.7. Okay. So, again. This one is 0.7. This one is 0.5. This one is 0.5. This one is 0.4. Okay. I-plus nyo, then divide by 4. Yan ang cap. Sige. Gamitin ng cellphone. Oh, what's the capping now? Point what?
0.5 dot.
5.
Point 5. 0.5. Yes. Okay. 0.5. Okay na? Alam na?
Yes, Doc.
Okay. Okay na? Dapat sabihin ako, okay na. Dapat naintindihan nyo. Ha? You did not do this in your lecture before, Okay, sige. So ngayon, sige. Okay, dapat maalala nyo. Mag-joke-joke na lang tayo para maalala nyo ako. Sige. Okay, next. Ando na. Okay lang. Where is the splinter hemorrhage there? Yes, this one is your splinter hemorrhage. Yan. Okay. Yan. That is a sign of ischemia. So that means there is damage at that area. Usually, ito, ano siya? May edema. So, sige. Estimate again. Give me the cupping of that optic nerve. Sige. Mm. 0.5 pa rin. 0.5 pa rin. 0.5 pa rin. 0.5 pa rin yan. Almost similar yan sa isa. Ang ano na yan, this. Okay. This is now, kanina, may splinter hemorrhage yun doon. O, tingnan mo ito. Yan. Wala na. Ito, wala na. O. Sa red free light ito, sa green light ito. Yan. Tingnan mo ang veins kasi may blood, kaya siya black. Okay. Ito, because the nerve fibers are still intact, may kita niyong striations. This one, wala na. Oh, wala na. Okay, dito meron pa mga striations. Okay? Sige, let's move na.
Yes po daw.
Okay. Oh, this one, asymmetry of the disc. So, magkaiba talaga. The right and the left eye. Kojali ka dito. Oh, give me now the estimate of the optic cup, the cupping of the right and the cupping of the left. Sige. Drawing ulit. The right eye muna. Okay na? You have an answer na? Right eye is
0.7 Doc.
7.
0.7. 0.7. The left is
0.5.
0.5 pa rin.
0.5 to 0.6 na actually ang left. Parang may pagkaano na siya. Kasi ito dito, manipis na. This part is already thinned out. No? Mga 0.6 na to. To 0.7. The right is 0.7. Okay? So, the visual field. It is defined parang poetic kasi si Traker, ha? An island hill of vision in a sea of darkness. Wow, hanep. Parang kay drama. Andali. Okay. Imagine kasi that island hill is actually your macular area. Towards the periphery, kasi the macula is that part of your retina na very acute ang vision mo. Towards the periphery, nagdi-diminish na ang vision mo. Ha? So, your visual field, okay, if you cover one eye, superiorly, you can see up to 60 degrees. 60 degrees lang kasi because of our supraorbital bone here. Ha? Limited siya. Inferiorly, 75 degrees dahil sa ating cheekbone. Ha? Nasally, dahil sa ating ilong. Lalo na pag matangos ang ilong mo. Ha? Siguro sa Pilipino, pwede ito maging 70 kasi pango. Oo, kasi pango. Ha? Kasi wala mong nag-aaro dyan. Temporally is 100 degrees kasi open na open dito. Remember, half of your eyeball is exposed temporally. Ha? Naka-usli siya temporally. So, mas makikita natin dito. So, that will be 60, 60, 75, 100. Okay? That's our visual field. Now, to quantitatively measure the visual field, we do your perimetry. Now, yun ang kinakita natin kanina. Okay? So, next. This is your visual field. This one is your macula. Okay? Towards the periphery, okay, the vision diminishes. Remember, your macular area is very active during on a lighted environment. On a dark environment, it is the periphery that will function. Okay? Now, this one has no more vision. So parang ang visual field mo, para siyang island. Ha? But it becomes acute at the center and at the periphery, nagiging less na ang kanyang field of vision. Now, remember, why is this so acute? Why is the macular area has a very good visual function? Why? What are in this, in the retina? What are in this layer, in this part of the retina? In your macular area.
Photoreceptors.
What photoreceptors are there?
The cones.
The cones. The cones are the ones responsible when we are in a lighted condition and it sees color, the size and the shape of the object, the size and the shape of the object. Okay? The periphery are rods, mostly rods. Okay? And this is active when you have in dark condition. At night, it is the rods. Assuming that you are in a dark environment, sorry, the rods are most active. Huh? Okay? So, most of your fibers come from this area. Sorry. Okay. Next. Scotoma is a localized defect or depression in the visual field. So, absolute. It is absolute when even if you will increase the stimulus, meaning, kasi when you test the visual fields, you will be introducing different light densities, intensities. Okay? So, in an absolute scotoma, even if you will increase the intensity, that part of the retina will still not see the light. Okay? Example of that is your blind spot. Your blind spot corresponds to your optic nerve. Your optic nerve does not see. It doesn't see. It is just the bundle of your optic nerve there, but the receptors are not there. Okay? Now, even though if you will shine the brightest light on the optic nerve, that optic nerve will never see your light because it has no photoreceptors. Okay? So, that is your normal blind spot. The perimetry machine will usually identify first the blind spot. Doon na siya mag-i-start, ma-identify kung right or left eye yan. Yan mo nang uunahin niya. Kung saan, thank you. Kung saan ang blind spot. Okay? So, the perimetry, yan ang may, every now and then, the machine will go back and forth to that blind spot to check, especially if the patient is not pressing kasi pag sa perimetry, mayroon niyang once the patient sees the light, magpe-press siya. Now, pag hindi niya talaga nakikita ang light, hindi yan magpe-press. So if the patient won't press, so sabihin, the machine now will check if that patient is just malingering or not just pressing, or the machine will go back to the blind spot again to check. Compare niya parati yan. Yun ang ginagawa ng machine. Nag-random check yan parati. The relative naman, the relative visual field effect, for example, sa flicker, sa less ang intensity ng light, hindi niya makita. But if you will increase the intensity, makikita na rin ng patient. Yun ang relative. Meaning, these receptors, meron pa siyang function, although weak lang siya. But ang absolute talaga, wala na talaga siyang, wala na talaga. Okay? So, wala nang kanyang receptors dyan. So, let's go to the classification of glaucomas. Okay. Your open-angle glaucoma. Now, the characteristics. It is insidious in onset, is slowly progressive, usually painless, and usually bilateral and asymmetric. Now, primary glaucomas talaga are usually bilateral. Ang primary. Kay open, kay close, pareho silang bilateral. And usually asymmetric. Ang ano lang sa primary kasi, painless. Kadalasan painless. Kaya, between angle closure and open angle, mas madali mo pang makikita early ang angle closure. Kasi mag-a-attack agad yan, may sakit. Pupunta agad sa doktor. Ang primary open angle glaucoma, kumakati na nga eh. Ang primary open angle glaucoma, walang pain. Sometimes the patient will just feel na parang mayroon siyang migraine headache. So, iinom lang niya ng pain reliever, ng paracetamol na mawawala. Not knowing na that is already part sa kanyang glaucoma. Kasi hindi severe ang pain dito. Unlike talaga sa acute angle closure glaucoma, sobrang sakit, namumula ang mata. This one walang redness. There is no redness. Magsusuka, namumula, lalabo bigla. So, pupunta agad sa doktor. The primary angle glaucoma, pupunta yan sa doktor pag sobra ng malala. Ang vision niya tunnel na lang. Kasi even though if your vision is tunnel na lang, you can still see 20/20. Kasi nandyan pang macula mo. Pero wala ka ng peripheral vision. You will still be considered as legally blind. when your visual field is the remaining will just be the central 10 degrees. Kahit 20/20 pa ang vision mo, you are legally blind na rin. Ha? You should not be given driver's license anymore. Yan. Ideally, ha? Kaya lang sa Pilipinas, kahit isang mata na lang nakakita, may driver's license pa rin. Yeah. So, the associated disorders, okay? Yan. Myopia, nearsightedness. Why? In myopic patients kasi, the eyeball is long, the sclera is stretched, so the eyeball will usually appear as soft. Pag ginanon mo, soft ang eyeball ng patient. But, pag kunan mo yan ng pressure, if the pressure is more than 20, that means may possibility na may glaucoma na yan. Kasi myopic patients, usually pag walang glaucoma, dapat ang pressure niya mababa. Kasi soft, ang sclera sobrang stretch. Ha? Pag mag more than 20 na yan, medyo may na yan, nag-start na yan mag-glaucoma. Madali nang ma-damage ang mata niya. Konting elevation ng pressure, madali nang ma-damage ang optic nerve. Of course, diabetes. Why? Basta anything that will decrease the blood flow to the eye, hypertension, especially diabetes, will usually lead to ischemia of the optic nerve, can also give you glaucoma. Okay? Yan. Basta ang ating ngayon, accepted na theory is the ischemic theory. Okay? This is your open angle glaucoma. As you can see, the trabecular meshwork is open. Open na open. Look, the aqueous can freely flow from the posterior chamber to the anterior chamber. The chamber is very deep. Look, the chamber is very deep. However, okay, this one is open. Now, however, there is still resistance to outflow in this part of your meshwork, of your trabecular meshwork. Sometimes, okay, especially in your carotid-cavernous fistula, in your mga aneurysms, the venous pressure is high. So the drainage to the venous system will be decreased kasi may resistance to outflow. Ha? So, yan, pwede yan mag-open angle glaucoma. And sometimes, in patients who have been taking steroids, di ba? In asthmatic patients, mga autoimmune conditions, they will usually take steroids. The steroids will lead to the deposition of glycosaminoglycans in this area. Ha? So, open nga ang angle niya. Ngayon to. Okay na? Okay. Now, in a steroid-induced glaucoma, it is usually an open-angle glaucoma. The trabecular meshwork are open. The angle is wide open. However, the drainage is not good because steroids will lead to the deposition of the glycosaminoglycans in the trabecular meshwork. So, ang mga butas-butas dyan nababara niya. That is why you will have increased IOP in chronic steroid use. Kaya ka nagkakaglaucoma, ha? Sa steroids. Okay? Sige. Next. Or, in certain conditions, in mga, example, in mga cancers, mga metastatic, may mga cells na dyan, ha? In uveitis, na may mga white blood cells dyan, anything that will block that one. But in open angle glaucoma, now primary, usually the angle is open, the trabecular meshwork is open, yet the drainage is still not good. Na? For some reasons, hindi natin alam kung bakit hindi siya nag-drain. But normally, the aqueous humor production is normal. Wala siyang kasi seldom ka nagkaka-glaucoma na mataas ang aqueous humor formation. Usually, ang drainage system ang problema. Sa glaucoma. So, this one is also an open angle glaucoma, the glaucoma suspect patient. If you have a family history of glaucoma, you will be considered as a glaucoma suspect patient. If your IOP is elevated of more than 21 millimeters mercury, chronically elevated, you can also be considered as a glaucoma suspect patient, even though if your anterior chamber angle is wide open. A suspicious appearing disc. Ano to? Malalaki ang cup, asymmetric cupping on both eyes. Okay. Next, the normal tension glaucoma or the low tension glaucoma. Okay. This resembles a primary open angle glaucoma in all aspects except that the IOP is within the normal range. Minsan nga ang IOP nito is 13 lang, yet ang patient may glaucoma pa rin. That means even though if the pressure is low, for example, the pressure is just 15, that 15 is already high for the optic nerve to survive. So walang kumbaga depende sa tao kung ano ang normal para sa kanya. That means if at 15 millimeters mercury, the optic nerve is still damaged, dapat pababain pa yan ng 9 millimeters mercury. Okay? Yan. At sure, to the lower the pressure, the better. Yan. Here are the theories why these patients develop normal tension glaucoma. It may be due to the abnormal susceptibility of the optic nerve head to the pressure, to that particular pressure, kahit ganyan na siya kababa. Or due to the poor perfusion of the optic nerve. This one talaga is the ischemic theory na. Okay? Yan. Next. The secondary open angle glaucoma. This one is the pseudo-exfoliative glaucoma. Okay? This is characterized by the deposition of a characteristic fibrillar material in the anterior segment of the eye. Makikita mo ang parang may line sa may sa endothelium mo. Para siya may deposits. Sandali. Sa may endothelium near your anterior chamber angle and even in your anterior chamber angle, makikita mo para siyang mga white, para siyang dandruff, parang balakubak na deposit on your anterior trabecular meshwork. And this comes from your basement membrane, probably from your cornea to your anterior lens capsule. You will see whitish debris on your trabecular meshwork. In this condition, the angle is open, but there are debris covering the meshwork. So here you will do laser trabeculoplasty. Parang you will create holes in your trabecular meshwork. Okay, next. Okay. This one, this whitish debris, they came from the anterior lens capsule. Yan. Para yan mga dandruffs, mahuhulog yan ngayon, magdideposit sa anterior chamber angle. Now, in Okay? So, in this kind of patients, okay, normally, the sonules here also has defect. Ang sonules dito, mayroon din mga ganyan na deposits. So, the sonules are weak. So, when you do cataract operation, usually nagka-complication ka dito na nagkakaroon ka ng sonulitis. Napupunit lahat ng sonules. So, minsan nahuhulog ang lens to the vitreous. Medyo delikado ito. Delikado ito for cataract operation. So, you have to be very careful during cataract operation because the sonules also has basement membrane defects. Okay, so meron mga deposits and they're very weak. Okay? And the same materials will deposit in your trabecular meshwork kaya siya nagkaka-glaucoma. Okay? Prognosis is usually not good in this kind of patients. Yan. Okay. This is your trabecular meshwork na makikita mo marami siyang deposits. Ha? So talagang barado na siya. The angle is wide open, yet there are a lot of whitish material in your trabecular meshwork. Okay? The pigmentary glaucoma. Okay. This is due to pigment dispersion syndrome. Huh? There is deposition of pigments in your corneal endothelium in a vertical pattern. So, this is what you call as your Krokenberg spindle. Huh? The Krokenberg spindle. There is also pigment deposition in the trabecular meshwork and in the lens periphery. So this one, kanina, the whitish fibrillar material deposition. This one naman are pigment deposition. Usually black pigments yan, black pigments. And where does black pigments come from? Of course, galing sa iris. Usually occurs in young myopic males between ages 20 to 50. Affected females tend to be older than the affected males. Okay? So the treatment is still laser trabeculoplasty, gagawa ka rin ng butas doon sa trabecular meshwork. Also medical, the topical anti-glaucoma medications. And if this fails, if these two fail, you will do na trabeculectomy. Okay? Trabeculectomy. Next. Okay. This one, this is your Krokenberg spindle. Pigment deposition. Nakikita mo yan? Okay. In your endothelium. Okay. Yan, the Krokenberg spindle. And in the trabecular meshwork, makikita mo. Ito yung trabecular meshwork niya, ha? Ayan, maitim na maitim. It is completely covered with black pigments. Okay? Yan na yun. Ito. Hindi. Ano yan? Nakikita na siya sa may iris na. Nasa anterior na ang deposition. Nag-ano na rin siya sa periphery. Tinan mo naman ang kanyang periphery. But the iris here is already, pale. Parang wala na, konti na ang kanyang, pigments. Kasi nandun na sa periphery lahat. Ito, dumidikit na rin. Ito, okay pa ang kanyang, doon, sa taas. Doon siya nalideposit sa taas. Pataas ang kanyang deposition. Now, because the iris pigments are usually predominant at the posterior surface of the iris, retroillumination ito. This is the back of the iris. May na siya. May pigment defect. Ito wala na. Wala na. This is your ciliary body, ha? Ciliary body yan. Sa likod yan. Retroillumination yan. Ito wala ng iris. Wala ng iris pigments. Puputi na. Sa likod. Naubusan na ng pigments. Ay, sorry. Ano ba yan? Ayan. Black na siya. Punong-puno na siya ng pigment. So, even though if the angle is wide open, hindi pa rin siya makadrain kasi ang trabecular meshwork mo barado na. Okay? Any questions? Okay. The lens-induced glaucoma. Okay. Pag sinabing phaco is lens. So that means the cause of the glaucoma is the lens. Okay. Phacolytic glaucoma is an open-angle glaucoma which occurs as a result of a leakage of lens protein from a mature or hypermature cataract. So the trabecular meshwork will be blocked by macrophages which have engulfed your lens proteins. And also, high molecular weight lens proteins that will be deposited in your trabecular meshwork. Ang iba naman, na-engulf na ng macrophages mo. Okay? So, because the cause is the lens, the primary treatment is the cataract extraction. You have Okay? So, since the cause is the cataract, the cause is the lens, so the definitive management is cataract extraction. So, once you remove the cataract, the glaucoma will disappear. Ha? Kasi mga secondary lang ito. Okay? Now, second is your lens particle glaucoma. Okay. This occurs when you have a penetrating injury to your lens. Okay? So, or after your cataract extraction, where the lens particle remains in your anterior chamber. So this one, the cortical materials from your lens will block your trabecular meshwork. Huh? So the management here will be the removal of the lens materials from your anterior chamber. And of course, you have to give your mydriatic and your steroids, including your anti-glaucoma meds. Okay? Yan. So, secondary glaucoma lang yan. So, parating removal of the lens ang management. Yan. The phacolytic glaucoma, nag-collapse na siya. The anterior capsule, para na siyang nag-wrinkled na. Kasi yung mga, ang cortical materials na nakalabas na. Huh? Okay. This is your phacolytic glaucoma. Yung mga patsi-patsi na yan, the white patches are your lens proteins na. Huh? The lens particle glaucoma. Yan. Penetrating injury ito. Pumutok ang cataract. Andyan ang kanyang mga lens proteins o kanyang cortical materials. Phacoanaphylactic glaucoma occurs after a penetrating trauma or surgery. Patient becomes sensitized to their own lens protein and develop a glaucomatous reaction about the lens. Teka nga pala, your lens is a normal part of your body. Bakit magkokos ng anaphylactic reaction sa mata ang lens mo if this is not foreign? Why? Here, give me the reason. It is your own. It is your own. Why will it cause reaction? Any? Give me other answers. Why will it sensitize the eye? Any guess?
Yung shape niya, Doc, it can cause build-up of allergens or protein.
Any other question? Any other answers? Sige. Remember that during your embryological development, during the first trimester, before the formation of your immune system, your lens proteins has been encapsulated already. So your body does not recognize those lens protein. Kasi nasa loob na sila ng capsule. Later part pang immune system mo, nauna ang lens mo. Binalot na siya ng lens capsule. So, your immune system is not aware that you have those kind of proteins. Okay? So, once the lens proteins will go out of your lens capsule, it will cause an allergic reaction inside your eye. Okay? So, it could cause uveitis. That is uveitis actually. Your fake anaphylactic glaucoma is a uveitic glaucoma. Okay? Understand? The lens protein is foreign to your immune system. Huh? Okay? Then, of course, your intraocular tumors in leukemic patients, where the cells will escape to your anterior chamber, thereby occluding your trabecular meshwork. Then, your ocular inflammations, your uveitis. And this one now, your drug-induced, pinakaano talaga dito is yung steroids. I have explained to you na about steroids, di ba? Okay? Bakit nga ulit? Bakit ulit?
If the glycan will be deposited in the trabecular meshwork.
Deposition of the glycosaminoglycans in the trabecular meshwork. Okay? Okay, dito na tayo sa angle closure. This develops because iris apposition to the trabecular meshwork blocks the drainage of the aqueous humor. Yun ang sinasabi ko na kanina. Okay, dito muna tayo. Isa-isay muna natin dito. Okay, the iris is pushed forward. Okay, in pupillary block. Imagine, the aqueous humor is produced from where? Aqueous humor is produced from where? Ciliary process. Where is your ciliary processes? Where is it located?
Chamber, Doc.
In the anterior or posterior chamber?
Anterior.
Ear chamber, Doc.
Walang audio po, Doc.
Wala. Okay, let's go to your aqueous humor formation na naman. Your iris, your ciliary body will produce your aqueous humor formation. Your aqueous humor. Your aqueous humor now will go to your posterior chamber. Nasa posterior chamber ang ciliary body, ciliary process mo ha. Then from your posterior chamber, it will go to your pupil. Okay, imagine, when there is pupillary block, there is membrane in your pupil. So the aqueous humor will just be stuck in your posterior chamber. Okay, imagine mo yan, hindi siya maka-pass through the pupil. So anong mangyayari ngayon sa iris? Maglulubo ngayon ng iris. Lulubo siya ngayon. Pag ganun na siya. Pag ganun. So, pag na ganito siya, it is pushed forward. So, nandito ang anterior chamber mo. So, dapat ganun siya. Ngayon, lumubo siya. Oh. So, nabara niya ngayon ang ano mo. Nabara mo ngayon ang trabecular meshwork mo, ang anterior chamber angle mo. Now, okay. So, plateau iris naman is different. Kasi if you will see, ano yan siya, malalim ang anterior chamber mo. However, diro-diretso lang siya nakaganon. Hindi siya pag ganon niya, diro-diretso. Hindi siya nagbabaw na pag ganito sa periphery. Talagang padiro-diretso lang talaga siya na ganon. Malalim siya dito, pero mababaw siya dito. Wala siyang angulation na pag ganon. Iba ang kanyang insertion na sa taas. Pag ganon. Yun ang plateau iris. Of course, tumors in your posterior, in the posterior, in your vitreous chamber will push the iris forward. Okay? It will push the lens, it will push the iris forward. So it will close the anterior chamber. Choroidal hemorrhage or effusion. Of course, this one, kasi pushed anteriorly ang choroid mo. Because of the hemorrhage or water underneath your choroid. And of course, this one also, okay, will push your iris anteriorly talaga sa may choroid area. So this one will push the iris anteriorly. Ito lahat. This one naman, the iris will be pulled forward by some mechanism or some elements. Rubeosis iridis. Rubeosis iridis meaning you have abnormal blood vessels in the anterior part of your iris. The anterior part of the iris has no blood vessels. Pag magkaroon niya ng abnormal blood vessels, usually in ischemic conditions of the eye, in diabetic retinopathies, in your central retinal vein occlusion, anything that will decrease the blood flow to the eye can produce rubeosis iridis. Now, rubeosis iridis is more common at the periphery and at the pupillary margin. Dapat walang blood vessels yan. Now, these are actually neovascular formation. These abnormal vessels, they will usually leak. Okay, so the inflammatory cells and your red blood cells will go out from this. So the inflammation caused by this will now cause retraction of the iris. Para siyang membrane formation, pulling the iris anteriorly. The inflammation now, pag nag-retract yan, it will cause the pulling of the iris towards now the posterior part of your cornea. So maglo-close na ngayon ang chamber mo. Kasi sa inflammation, nakita mo ang if there is inflammation kasi, iris kasi, when inflamed, will stick to any part of the eye that is nearest to it. Okay? Now, kung nandito yung inflammation, ang pinakamalapit sa kanya is cornea. So magdidikit siya dito. Now, if the neovascular formation naman nasa may pupil at yan ang mag-inflame, didikit siya. Anong pinakamalapit sa kanya sa pupil? What part of the eye is nearest to the pupil?
Lens.
The lens. Kung saan siya malapit, didikit yan. Ganyan ang iris. Madali siyang dumikit pag inflame siya. Kahit saan siya malapit. So kung ang rubeosis sa may iris, sa may pupil, didikit yan sa anterior chamber angle, it will cause pupillary block. So dito ka sa iris push forward. Dito. Pag sa may pupillary margin. Pag if the rubeosis will appear at the peripheral portion of the iris, this will block, this will stick, the iris will stick to your cornea, then it will block now your anterior chamber angle. Okay? Yan. Basta, iris has no blood vessels. The anterior portion of the iris, no blood vessels. Then inflammation. Wala pa rin? Okay. So, this one is just like my explanation kanina. Basta inflame ang iris, it will stick to any part of the eye that is nearest to it. Okay? Now, your ICE syndrome, okay? Para itong para ito kanina, yung pseudoexfoliative glaucoma. It is like this one also. This will produce membranes also at the periphery. Then this membrane, it will retract, pulling the iris towards the cornea. Ganun ang nito, ang mga mechanism nila. Okay? Next. Okay, ito na ngayon. So, is your ciliary body. This is your posterior chamber. Ha? Nasa likod ang ano. This one are your zonules. Oh, look. If your iris bows like this, oh, it will now push the iris towards the cornea, thereby closing your anterior chamber angle. Okay, nandito nakatago ng trabecular meshwork mo. Look, now, if you will apply, usually pag ganito, okay, nakaganyan ang ano, nakaganyan ang iris mo. Para itong mid-dilated, nakita mo to, mid-dilated siya. So if you will place pilocarpine, okay, imagine ha, pilocarpine, what will pilocarpine do? What's the action of pilocarpine?
Reduces IOP, Doc.
How? It will cause pupillary constriction. Okay, so, ito mid-dilated. Ngayon, the pilocarpine will cause constriction. So, the pilocarpine will pull this one, will pull that one. So, ngayon siya nakaganyan. Pag pinul niya yan, papunta na dito, mag-flatten yan. So, pag mag-flatten yan, aakyat yan dito. So, lalabas na ngayon ng egg dyan. Then, mag-o-open na to. Yun. Yan ang mga effect ng gamot. Okay? Kasi ngayon, mid-dilated siya. Nandito siya. Oh, nakabara siya. Ito, the last roll of the iris usually is very, parang ang kanyang curvature, parang mataas. Kaya talaga madali siya the pilocarpine will usually pull the last roll of the iris away from the trabecular meshwork. Yan. Kaya mag-open yan. Yan. So, open na yan, makakapasok na yan ng aqueous dyan. Ito naman, mag-flatten yan. Na-imagine na ninyo anong effect ng pilocarpine ngayon? Ha? Dapat maalala niyo yan. Kasi mahirap ang pharmacology pag wala kang iniisip. Wala kang na-imagine. Okay? Okay? No. Sa ngayon, hindi na lahat ng acute angle closure glaucoma nag-aano tayo. Iba na ngayon ang depende kung anong mo. Later, we'll tell you anong effect niyan. Anong effect ng mga ganito. Kasi, in treating glaucoma, either you will decrease the aqueous humor formation or you will increase the drainage system. Yan. Pag mid-dilated talaga, in acute angle closure glaucoma, the pupil is usually mid-dilated. So you have to constrict that during the acute phase. To constrict mo talaga yan. Now, assuming na wala kang hypermature cataract, mahirap kang mag-constrict in hypermature cataract, baka pumutok ang cataract mo. Iba ang effect niya. So, dapat walang cataract ang pasyente mo or the cataract is just beginning. Okay lang yan. Yan. Yan ang plateau iris mo. Malalim ang chamber mo. Ang anterior chamber mo malalim dito. Pero dito, mababaw. Kasi ang kanyang insertion mataas. Naka-flat lang siya ng ganun. Hindi siya katulad ng normal kanina iris na nakaganon. Para siyang may nagbabaw dito. The insertion here is so high. Yan ang plateau iris. This is your, the view from your anterior chamber OCT. We have that at the center. We have that. We have this. But we seldom, sometimes I don't do gonioscopy na kay, tamad na ba? So we just request this one to see if the angle is open or closed. Katamaran ba? Katamaran. Ginagamit na ng technology. Neovascular. Ba't wala akong makita dito? Nasaan bang aking ano? Hindi ko makita. Rubiosis. This is not clear. Itong ano na to. Ay, ito. Kasi ano ito, foreigner kasi ito. This is a foreigner's eyes. Sa EEO, foreigner's eyes. Rubiosis in a foreigner's eye will usually appear parang hyperpigmentation. Pero actually, if you will look at that in the biomicroscope, they will appear as small vessels. There, small blood vessels. Ha? Yan. Yan. Ayan o. The blood vessels at the anterior chamber angle. They will usually leak. Magli-leak ang inflammatory cells, red blood cells. So they will produce membrane. Yung membrane na yan, mag-retract yan. Mag-retract. Pag nag-retract, ihatakin niya ngayon ng iris pupunta sa cornea. Ha? Yan. Yan na nga o. Hinahatak na niya doon. Close na siya. Dito open pa. Dito hinahatak na niya. Oh, this one is iris bombay. Meaning, yung iris mo parang balloon. It's balloon. Nag-balloon out na siya towards the anterior chamber because of this one, the occlusion. This is your seclusio pupillae. Seclusio pupillae. Because there's a membrane that eluding the pupil. That is your seclusio pupillae. Oh, this is your peripheral anterior synechia due to inflammation. Yan no, inflammatory membranes yan. Tinakpan na niya. Tinakpan na niya ang trabecular meshwork. At hinatak na niya. Mababa, ano na rin. Halos mag-close na. Okay? Any questions? Marami ang glaucoma, ano? Sige. Pero actually, this is common in our, between uveitis and glaucoma, mas marami tayong glaucoma. Mas marami tayong glaucoma. And wala tayong age predilection, mga bata pa ngayon, ang problema. This is your pupillary block. The most common cause ng angle closure glaucoma. Ito talaga pag ganito, mataas ang pressure nito, tatakbo agad dito sa doktor. Masakit ang mata nito, masakit. Yan. Okay. This is usually bilateral. Pag mga primary glaucomas, bilateral talaga yan. Ha? The manifestation, kanina painless. This one has pain. Blurred vision talaga. Sudden. Then, colored halos around light. Nausea and vomiting. Bakit nga ba may color? Bakit rainbow-colored halos? Na-experience na ninyo yan? If you have allergic conjunctivitis, if you have sore eyes, makikita ninyo around the light may rainbow. Na-experience naman ninyo yan?
Yes.
Ha? Yung rainbow around the light? Ha? Sige, bakit nga ba? Especially in glaucoma, bakit mayroong ganyan? Ha? Let's talk physics again. Optics and refraction. Sige. Kasama yan sa optics and refraction na yan, ang kanyang bakit ka nga ba mayroong ganyan? Sige. You give me any answer. Sige lang. Kung paano nyo naintindihan yan para ma-correct natin. Sige.
Doc, nagdi-disperse na yung light, yung white light nagdi-disperse because of napupuno yung aqueous. Doc, when there are kanang spots in the cornea, Doc, and the light will go inside, imbes straight line siya, Doc, it will bend or scatter. So,
Sige. Any pa? There's some truth to it. Sige, I will explain later pa. Sige, ano pa? Any Any answers? Sige. Sige lang. Sige lang. Walang ano ito. You answer me anything. Uy, hindi ako naniniwala sa mga matalino, bobo, wala akong ano doon, ha? If you're a doctor, just be a doctor. Ha? You are in the most noble profession. Our profession calls for kindness and humility. Ha? Mag-ano naman ako sa inyo. But always remember this. What is considered wise in this world is stupidity in the eyes of the Lord. Ha? So, wag kayong talino-talino kasi hindi, ako matalino lang ako sa, sa klase. Ay, hindi ko alam kung matalino ako sa totoong.
Ba't no audio pa?
Okay? Sige, any answers? Sige, ikaw. You have any idea? Okay. Let's, what happens, sino ba nagda-drive dito? Sino nagda-drive? Sino nagda-drive dito? Sige. Everybody drives? Okay. What happens if you are driving tapos umulan? Then huminto ang ulan. Then umaraw. Ano nangyayari sa windshield?
Moist. Nagpa-fog, Doc? Moist.
Pag tinamaan siya ng araw, what do you see?
Nagkakaroon ng rainbow.
Now, imagine your cornea as your windshield. When you have an increased IOP, your cornea is edematous. Ha? So, edematous yan. Normally, your cornea is dehydrated. Ha? Dapat hindi yan, dehydrated because of your endothelium. Now, pag mamagayan, because of the increased IOP, mamamaga, may tubig. So, your cornea now will act like a prism. Okay? May water na siya eh. So, mabaga siya, it will act as a prism. Once the light will pass through your cornea, it will now disperse the light into your rainbow. The spectrum of your color. Ha? O, kaya siya may rainbow. Okay? Okay na? Ha? Oh, naintindihan na ninyo. Okay, yun ang Hindi yan Just like when you have Yes, just like when you have sore eyes actually. Kasi what causes the rainbow is your tears. Malapot ang tears mo para sa nagiging prism. Ha? Pag may sore eyes ka, sobrang luha, ha? Hindi ang cornea kasi ang cornea mo is normal in your sa tears mo 'yan, okay? Then nausea and vomiting. Bakit ka nga ba masusuka pag mataas ang pressure ng mata mo, aside sa pain, pag masakit talagang ulo natin, bakit ka ba masusuka? Bakit ka magsusuka? If you have an increased IOP, an acute increase in IOP, why? Now, remember that if you will touch your eye, if you will manipulate your eye, especially if you will hold one of your extraocular muscles, you will stimulate vasovagal reflex. Huh? Okay? Huwag mong hawakan ng mata mo, loko-loko kayo. Never press on your eye. Ha? Kaya nag-stop ang mo, mabagal ang heart rate nyo. If you will press on it. Now, if your if your IOP is high, you will stimulate your vagus nerve. Ha? Kaya mahusok ka din kayo. Ha? Pag sudden increase. But in your chronic increase, just like your open angle glaucoma, hindi mo yan maranasan. Pag mga sudden lang. Ha? O nga pala, your cornea will often be edematous if your IOP will reach 50 to 55 millimeters mercury. Karamihan yan. Mamamaga na ang cornea. Puputi na ang cornea. Mga less than that, mga 30, hindi pa yan. Hindi pa kadalasan hindi. Pag, mostly talaga, pag more than 50 millimeters mercury, mamamaga na yan. So instead na makintab yung cornea mo, para siyang dull. Para ba siyang, para bang, di ba, the fish, if it is not fresh, parang namumuti ang mata, di ba, ng fish. Parang ganun. Okay. So of course, the signs, your increased IOP, your mid-dilated, sluggish, and often irregular pupil. Mid-dilated yan, ha? Your uveitis, usually your pupil is constricted. Your eye is also painful, your eye is red, but the pupil is constricted. In acute angle closure glaucoma, the pupil is mid-dilated and is sluggishly reactive to light, sometimes not reactive. Ha? Pag mataas ng pressure. Okay? So, pag mid-dilated yan, pwede ka magbigay niya ng pilocarpine. Kaya lang, mahirap ang pilocarpine mag-effect kung mataas na mataas ang pressure. You have to give other medicines to decrease the IOP. Now, there is corneal epithelial edema, o kaya yan, meron kang halo. The congested episcleral and conjunctival blood vessels. Shallow anterior chamber. Okay? And actually, hindi mo ito makikita yung mild aqueous cells and flare sa anterior chamber. Bakit? Hindi mo makikita masyado yan kasi nga you have corneal edema. So makikita mo na lang yan pag wala na ito. Pag wala ng corneal edema. Ito. Mahirap makita yan. Okay. Workups. Of course, you have to do gonioscopy to okay. To know if how the extent of the closure of the anterior chamber, you have to do gonioscopy. Okay? Of course, you have to do perimetry to see the damage. Lahat ng glaucoma, ganito ha, gonioscopy, perimetry. Of course, una muna is fundoscopy. Kasi how will you suspect if the patient has glaucoma kung hindi ka muna mag-fundoscopy? Fundoscopy muna, gonioscopy, then perimetry. Now, mayroon na tayong optical coherence tomography of the optic nerve. Okay? Kasama na yan, ha? Sa workup na yan. Yan na ang bago ngayon, OCT. Okay? Ito muna, fundoscopy, gonioscopy, perimetry, ocular, optical coherence tomography of the optic nerve. Okay? Or if you want to see talaga, if you want to see the actual appearance of the eye, of the anterior chamber angle, you can also request for OCT of the anterior chamber. Okay? Then treatment in angle closure glaucoma. Okay. Pumunta nga tayo dito. Ayan. In acute cases na ganito, napababa mo na siya ng konti. Wala kang daanan dyan ng aqueous. You can do laser iridotomy. Magbubutas ka dyan. Yan ang laser iridotomy. Bubutasin mo ang iris dyan para i-divert mo ang kanyang drainage from the pupil. Dito na siya dadaan, diretso na sa anterior chamber. Okay? Iridotomy means you create a hole in the iris. Okay? Para i-divert mo ang kanyang kanyang route from the pupil to here na. Okay? Yan. Especially kung mayroong dito, occlusion. Okay? Okay. Ito, Okay na yan. Mga ano na yan. Mga chronic angle closure. Okay. Dito na tayo. Ito na. Of course, clinical evaluation, history. Family history of glaucoma. Importante. Ha? History, medical history niya. Kung may hypertension, diabetes. Okay? Of course, the refraction, should know the refraction sa mga high myopes. The high myopes and high myopes are prone to open angle glaucoma. High hyperopes, ang mga hyperopic patients kasi the eyeball is small, is short. Para siyang compressed. So they are usually prone to develop angle closure glaucoma. Ha? Myopes, open angle glaucoma, ang hyperopes, because they have short eyeball, they are prone to develop angle closure glaucoma. Okay? Now, the external examination of the eye, the lids, ang brows, anything, you examine from outwards, inwards. The pupil examination, biomicroscopy, perimetry, tonometry, gonioscopy. Yeah? The ophthalmoscopy, then the OCT na. Okay? Ito na tayo sa pharmacology. Okay. So, these are the classification of your anti-glaucoma medications. Okay. Ano ba itong mga asong to? Ingay. Okay. The beta-adrenergic antagonists. Okay. The mechanism of action. It lowers your IOP by reducing aqueous humor formation. The mechanism is unknown. How this decreases the IOP, this is unknown pa. Ito dati ang gold standard ng glaucoma, timolol. Itong pinakaunang anti-glaucoma agent, beta blocker. Mga beta blockers. So, timolol, betaxolol, levobunolol. Now, what is the danger of giving beta blockers on patients? Again, when not to give this one? Huh? When not to give beta blockers? In patient with asthma. Okay? And of course, patient with very low heart rate. Heart rate. Ha? Kapag ang heart rate mo less than 60, mag-isip ka. Baka matumba pasyente mo, mag-collapse. Kasi kahit 1 drop lang yan, can actually decrease your heart rate up to 30. Huh? That's the problem when the cardiologist has already given beta blockers on the patient. Pag binigyan mo pa siya ng topical, doble na ang kanyang ano. Minsan pag okay. Be very careful with this, ha? Kasi may bata akong pasyente na biglang bumaba ang heart rate, nahilo. Ha? Yan ang problema. Now, next, your alpha adrenergic agonists. Okay? Isa lang ngayon ang available sa market, your brimonidine tartrate. It lowers your IOP by reducing aqueous humor formation. Ganun pa rin, pareho sila. Ang beta-adrenergic antagonist, ang alpha-adrenergic antagonist, they both reduce IOP. Parang iba, no? Parang kakaiba. But they both, pareho ang mechanism nila, hindi pa rin. These are still unknown mechanisms. How they decrease the IOP. Okay. Now, your parasympathomimic agents. Ito na to, ha? They reduce IOP by causing contraction of the ciliary muscles. Yan ang sinasabi ko kanina sa inyo. The ciliary muscles. Okay. The direct acting is your pilocarpine. They affect the motor end plates That effect is similar to acetylcholine. Your indirect acting, your dose that inhibits your acetylcholinesterase, ito mga hindi natin ginagamit dito. Ang ginagamit lang sa Pilipinas is topical na pilocarpine at saka ito na carbachol, which we usually use during cataract surgery to constrict the pupil. Okay? Now, when your ciliary muscles are contracting, remember your uveoscleral outflow happens in your ciliary muscles. Remember, the 20% of your aqueous humor will drain through your uveoscleral outflow through your ciliary muscles. Okay? So, when you contract the ciliary muscles, it will also increase the drainage of your ciliary muscles. Okay? Through your ciliary muscles. And it will also pull your iris, the root of the iris, away from your trabecular angle, from your anterior chamber angle, thereby opening your trabecular meshwork, your anterior chamber, your drainage system. Okay? Na-imagine nyo kanina, yung sinasabi ko na yun na yung accordion, di ba? Once na yan, magpupul siya, pupul niya towards the center. So ang fold dito mawawala na ngayon sa angle. I-open na niya. Okay? Yan. Your carbonic anhydrase inhibitor, okay? This reduces your aqueous humor formation by direct inhibition of carbonic anhydrase enzyme in the ciliary body. Kasi carbonic anhydrase enzyme is important in your aqueous humor formation. So, the oral acetazolamide is oral, dorzolamide and brinzolamide are topical. Okay? So, later, then we will discuss muna the hyperosmotic agents. Your hyperosmotic agent does not decrease the aqueous humor formation, nor it increases your aqueous humor drainage. Wala doon ang effect niya. Ang gagawin niya is, it will shrink your vitreous. It will remove water from your vitreous chamber. Okay? Thereby decreasing the volume of your globe. Parang buong eyeball, i-decrease niya ang IOP. Lahat, pati yung vitreous volume mo. Wala sa anterior chamber, wala sa posterior chamber. Ang effect niya, nasa vitreous chamber. Okay? So, that is the effect of mannitol. Your glycerin, your urea, and isosorbide. Now, in cases of acute angle closure glaucoma, when the pressure is so high, usually ang pressure umaabot ng 80. May mga abot ng 80 plus, wala na nga sa applanation, di mo na maikot, wala na. Hindi yan mag-i-effect ang eye drop mo. Never mag-i-effect yan sa taas ng IOP. So when the patient is in front of you, dapat you have to do everything in your power to decrease that IOP bago mo siya pauwiin, kahit man lang kalahati. Kung 80 yan, kahit man lang 40. Okay? So, to decrease that fast, ang pinakamabilis is mannitol. Within 30 minutes, mag-i-reduce yan. But, mannitol, fast drip yan, fast drip. 1 cc, mga, 1 to 2 cc per kilogram. Pero usually, pag mga 60 kilograms, we usually give fast drip, 150 cc, fast drip na yan. Then, take the IOP after 30 minutes. Pero, ang problema sa mannitol, after 30 minutes of its effect, babalik ulit. Kasi mawawala na yan sa niya, yung sa blood-brain barrier, madali yan bumalik sa mo. Madali yan mag-equalize. Sa blood-retinal barrier, kahit sa blood-brain barrier mo, in 30 minutes mag-equalize na ang intravascular at saka yung vitreous chamber, magpapareho na ang pressure niyan. This is fast acting, yet the effect will also fade faster. So how will you stabilize that? While giving mannitol, give acetazolamide. Kasi ang acetazolamide, ang effect niya is 8 hours. So, while you are reducing the IOP fast, pagkawala ng effect ng mannitol, nandyan ang effect ng acetazolamide mo. Okay? Then, paihiin mo muna ang pasyente. Paihiin mo ng paihiin. Then you take the IOP after. Ha? Ganun yun. Then, pag bumaba na ang IOP, doon ka na ngayon mag-start ng pilocarpine mo. Kasi mahirap mag-constrict ang pupil pag sobrang mataas ang IOP. Why? In a very high IOP, your ciliary muscles, your iris muscles are ischemic. Ha? Ang blood supply niyan bagsak. Hindi yan mag-i-effect masyado. So you have to establish first the blood flow bago mo mapakonstrict yan. Ha? Okay? Yan.
Okay po, Doc.
Yan ang ano. Basta in emergency cases, dapat monitor talaga. Then your prostaglandin F2A analogs, it does not have an effect in your classical outflow system, but it will only affect your uveoscleral outflow, the 20%. These are prostaglandin analogs. So para itong the prostaglandins that will cause really allergy. Kaya pag pinapatak mo to, mapulat talaga ang mata ng pasyente. So these medications are given once a day only at bedtime. And among the three, ang pinakauna dito is latanoprost. Ito ang pinakauna talaga. Then, sumunod ang travoprost. Then, the same, ang travoprost at saka ang tafloprost. They have the same, kung sa strength. Latanoprost ang pinakamababa. Next is travoprost and tafloprost. Meron ng bago kasi dito. Tafloprost. Ang pinakamalakas is bimatoprost. This is the synthetic form, a prostaglandin F2A analog. Ito ang pinakamalakas, ito naman ang pinakamalakas mag-allergy kasi synthetic to. Yan. So they are given once a day at bedtime. Now, if all else fail, hindi po pala, laser surgery muna. Pag open angle, laser trabeculoplasty. Pag angle closure, laser iridotomy. Okay? Igagawa ka ng butas, iridotomy, magawa ka ng butas sa iris. Laser trabeculoplasty, gagawa ka ng butas sa trabecular meshwork. Okay? Now, if all else fail, laser at saka eye drop, filtering procedure na. Trabeculectomy na. Surgery na talaga. Okay? Yan. So, any questions? So, naintindihan na ngayon ang effect ng mga gamot? Yan ang doon eh. So, pilocarpine. Now, what will you do if the patient has corneal edema? Kasi hindi mo ma-examine ng maiging pasyente habang may corneal edema. Habang mataas ang talaga, while the IOP is still high, may corneal edema pa lang yan. May corneal edema pa yan. Pagbaba ng IOP by 20, mga 25, less than 30, dyan na ngayon mag-clear up ang cornea mo. But to have a faster effect on the corneal edema, para siya mag-clear up agad, no, nakamonitor ka na eh. You will instill sodium chloride eye drop. You have to dehydrate the cornea by instilling sodium chloride. Yan. Mag-clear up na yan pag mababa na ang pressure. Kasi kahit ka naka-sodium chloride pero mataas pa rin ang IOP mo, corneal edema pa rin yan. So, mag-i-instill ka lang pag naka-monitor ka na, naka-acetazolamide ka na. Okay? Acetazolamide cannot also be given for a very long time. Mga emergency lang ito. Hindi siya pwedeng maintenance meds. Remember, it can increase your blood glucose level. It can deplete your potassium. So, magte-tremors ang pasyente mo. Ha? Hindi makakatulog, walang lasa ang pagkain. Magkaano talaga yan, magreklamo yan. Ha? Okay? Mannitol naman, if the patient is admitted, you can give that fast drip. Okay? If the patient is admitted, you can give mannitol fast drip every 8 hours. Ha? And alongside with your acetazolamide. Now, pag diabetic ang pasyente mo, you have to inform the doctor, the diabetologist of the patient that you're going to give acetazolamide. Ha? Huwag kang magbigay ng acetazolamide pag sobrang mataas ang blood sugar ng patient mo. Dapat you have to talk to the diabetologist para mag-insulin muna. Ha? Kasi kawawa ang kidney niyan. Pag mataas na lahat, alam mo na yan, nag-ano dito sa kidney, ang acetazolamide mo. Okay? So, what else?
So, question po, Doc. So, meron tong kanang maintenance medication, Doc, or if lower na yung IOP than surgery na?
You have to go back na to your eye drops muna. Okay? You have to, now, pag angle closure talaga, pag clear na ang anterior chamber, medyo mababa na ang pressure. For example, ang gusto man lang ma-attain is mga 30, you have to do laser na. Laser surgery muna. Laser surgery. Laser surgery. Kasi you have to divert the flow of your aqueous. Oo. So, acute muna. Then proceed to laser. At the same time, dapat habang ang pag pinauwi mo ng pasyente, kasi wala nang mannitol yan. So, ang pwede mo lang ipauwi sa pasyente, acetazolamide plus eye drops, anti-glaucoma meds. Na? Papauwi ka na ng eye drop. At tapos, pwede mong pabalik na ang pasyente or kahit pag nandyan na, clear na ang cornea, you can do laser at once. Kaya lang, hindi ako ganun ha. Although, ganun naman talaga ang management mo. Do laser at once. Pero alam mo, during acute phase, in pain ang patient, kahit mababa na ang ano niyan, IOP, okay na, parang I don't want to do, parang add injury sa patient. Gusto ko muna magpahinga muna ang pasyente kahit 1 linggo. Bago ako mag-laser. Why? During acute phase, maga ang iris. Magli-laser ka. Pag maga ang iris, tinamaan mo yan, masakit ang iris. In pain ang patient dyan. So, the more that you will elicit, you will elicit inflammation of the iris. Ha? Ano yan eh. Parang better muna na pahinga muna ang mata, then after a week, do laser. Ano pa ako medyo conservative pa ako masyado. Kasi kung gagawa din lang ako ng mga procedure, I want it to succeed, not to fail. Kasi kung inflame din lang ang iris, mag-close din yan. Diba? Doon dikit yan kahit saan eh. Mag-close din. So, don't be in a hurry. Para may time ka pa mag-isip na maigi after a week. Kasi, dyan, close pang angle. After a week, pag mababa na ang IOP, do gonioscopy again. Tingnan mo. Kung nag-open, ilang percent nag-open. Kasi kung naka-pilocarpine ka na, possible yan na magbukas pa rin eh. Diba? Yun. You have to re-evaluate. You have to re-evaluate. Kasi hindi ka rin makakagawa ng ano mo. During the acute phase, hindi ka naman makakagawa ng perimetry. Futile yan. With an edematous cornea, mahihirapan ang pasyente dyan. Usually ako nagpapagamo ng ganyan. Kaya minsan ang mga nurses ko Dok, pinapagawan ng glaucoma workup, ang taas ng IOP. That's the problem. How can you do a glaucoma workup with a very high IOP? You cannot even dilate the patient uh, when you do OCT, you dilate the pupil. So, paano ka mag-dilate in an acute angle closure glaucoma? Yan ang problema namin parati. Cannot, now yeah, you have to manage, you have to bring down the pressure first before doing the diagnostics. Kasi yan, medyo delikado sa patient. Kasi there was a time nga, we have an ophtha. She did diagnostic, nag-dilate siya, acute angle closure glaucoma. So, nag-attack ang patient. Now, ang pasyente, nagreklamo talaga ng katakot-takot sa DOH. Umabot pa kay Duterte ang sulat.